So this is a special day for us, and I just want to welcome our guests who have joined us. Today we are celebrating the William Pevec Lecture. I am very sorry that Dr. Pevec, and he sends his apologies, could not be here today and for some unexpected circumstances that occurred. But I will take this opportunity I need to grow another 2 inches and things would really work out better for me, but I'm not sure it's going to happen. Anyway, to highlight not only Dr. Pevec, who, as most of you know, and it makes me sad now that he's been retired enough that not everyone here might know him, but was our chief of vascular surgery here for 27 years. And the family of a patient, James Kinney, who Dr. Pevec just took care of in the same way he took care of everyone, with compassion, dignity, respect for their challenges. His family was moved to make a donation in honor of the family and in honor of the great care that was received by Dr. Pevec. And we are so thrilled that the family has been able to come as often as you have. I want to just give you a little challenge. I most recently gave an invited lectureship in London, which has been going on for 75 years. And the next generation of family was still there to honor their now departed in World War I physician that was originally the reason the wife made that donation. So there's a challenge for the family and the next generation there, because I have to tell you how special it was for me to know that this family, honored the legacy of their loved ones. So thank you so much for coming. It's a very special and meaningful, not just hopefully to you, but to all the people that come beyond. So thank you. And with that, so this gives us, so what are these endowed lectureships and why are they important? They're important because not only do they honor the people who make it happen, but they also give us an opportunity to bring distinguished individuals to our institution, to broaden our horizon about perspectives, to keep us not from just being our own silo talking to one another, but bringing distinguished people to speak with us and spend time not only in this formal setting, but with our trainees. So Dr. Humphreys, I'm going to invite you to introduce our visiting professor today. Thank you.
Good morning. I'm Misty Humphreys. I'm the interim chief of vascular surgery, and thank you for being here. Again, Dr. Pevec had an unexpected emergency at the last minute and wasn't able to be here. And for those of you who knew Dr. Pevec, if you ever want to, and those of you who don't, if you want to get to know him, you can just spend time operating with me and Dr. Kwong. And if you don't want to get to know him, don't come to our room, because we're still very much like him. In fact, sometimes Dr. Kwong and I argue about who's more Dr. Pevec like in different ways. So it's a joy. But we are extremely excited to have Dr. Melissa Kirkwood here. Dr. Melissa Kirkwood is the chief of vascular surgery and endovascular surgery at UT Southwestern. I've known her for several years. I became familiar with her mostly whenever she ran the leadership development program for the Society of Vascular Surgeons. You started that program about 4 years ago, I believe. You're in the 4th or 5th iteration of it now. But Dr. Kirkwood had an idea to bring leadership training to young faculty through the Society of Vascular Surgeons, and also made that happen. And it has been something that's gone on to provide exceptional training. And so it's something I'm I think was very important. I was one of the first members to go through it. Beyond that, she is a leader in radiation safety, and she has presented all around the world talking about changes and how we can improve our own ability to protect ourselves as surgeons. For those of you that don't use radiation frequently, it's invisible. And so imagine standing next to an invisible poison all day, every day sometimes, and not realizing that you could be hurting yourself. And so she is going to shed a little bit of light on that. She also most recently trained Dr. Melissa Keller, who is our new faculty, is here, who joined us last year from UT Southwestern. And so it's with a great honor that I introduce Dr. Melissa Keller, or Kirkwood. See how hard it is? Kirkwood Keller. be here. Let me just, okay, there it is. You loaded it up. Thank you so much, Kristen. Okay, again, thank you so much. Such an honor to be here. And for those of you who don't do radiation, super sorry. It won't, hopefully you'll pick up some pearls. But it affects ortho, it affects thoracic surgery when they do, EGDs under radiation guidance. And so there are some pearls hopefully you'll take away from this. So what do I, oh, this one? How do I advance? Oops, sorry. So this one's forward. Thank you. The one that says forward. Imagine that. Okay. All right. These are my disclosures. So today we're going to run through a couple of things. We're going to address changes in the new radiation safety event policy, define some commonly used dose metrics, and describe different forms of radiation injury to our patient and to the operator. We're going to look at which cases that vascular does that are really high dose and discuss some new advances. So some numbers to know. So the National Council on Radiation Protection and Measurements has defined a substantial radiation dose level for any case that reaches 5 gray reference air kerma. And we'll talk about what that means in a minute. So what that means is if you're doing a case that hits 5 gray, you're supposed to follow that patient in your clinic for the next 2 years, looking at their skin to see if they get a skin injury. And then in the past, the Joint Commission defined any event over the last 6 months that reaches 15 gray. So that means your patient comes in and gets a coronary, has a STEMI, and they get 2 gray. And then they go for IR because they get acute cholecystitis, and then they get another gray. And then they rupture their aneurysm. And so if they get to 15 gray over 6 months, that was a sentinel event. They've changed that policy now. And the reason why it's important to know that is just because if you're doing the right thing as an interventionalist, you're keeping your table high, your II low, you're doing all the things, then most likely you won't get a sentinel event. So the patient has to have the skin injury for there to be a sentinel event, and you have to have not adhered to best operating practice when you did the case. So when you have a high dose case, people are looking at it, your medical physicists review it, and they can say how high your table was, if you used a lot of angulation, whether you collimated, and you did the things that's best operating practice. As long as you do that, then it's very hard nowadays to get a sentinel event. So what are some dose metrics? So people talk about fluoroscopy time. That is typically a poor indicator of dose, and that's because it omits all of the dose you get from the digital acquisitions, is when you step on the pedal and the bones go away, right? So that's high dose. So the fluoro time doesn't include that. The dose area product is the dose times the cross-sectional area of the beam. That is a better approximation of your cancer risk, okay? Your cumulative dose area products for multiple cases. The reference air kerma is basically the dose of the case. It is the best approximation of patient skin dose. So the machine doesn't give you patient skin dose. The medical physicist calculated on the back end if there's a high dose case. But the reference air kerma is all it is the dose at a reference point, which is 15 centimeters from the X-ray tube, where a 70 kilogram male's skin usually lies, right? So if you're super obese and the table's lower, you can imagine that your skin dose is going to end up being higher than your reference air kerma if the patient's lower. So there's different things that go into all of this. So the radiation injury. So broken down mostly into deterministic effects and stochastic injury. So deterministic effects is skin injury, typically in the patient, or I guess on your hand, if you always have your hand in the beam, and cataracts, mostly in interventionalists. It's a dose-related response, and it has a threshold level. So you have to achieve a certain threshold to get it. Whereas your cancer risk, your stochastic injury, is not dose-dependent. But obviously the risk of it increases as you're increasing in cases and exposure. So this is a very popular table from several years ago that defines when you can start seeing something. So the lowest threshold that's been detected is a 2 gray skin dose, so not a rack, but a skin dose. And that was early epilation or redness on the patient's back after 2 gray. So it can happen at 2 gray. The good news is it doesn't usually. So we looked at this in a retrospective setting many years ago. And then once we found basically no skin injuries in all our patients that had super high doses, we did a prospective study actually purposely examining their back at all of these follow-ups. And what we found was, even though we had a lot of high dose cases, I mean, there were some at the time that were greater than 10 gray, there were actually no skin injuries detected. So what that tells us is skin injury is a complex problem. It might have some pre-existing conditions, maybe autoimmune disorders or Sjogren's or lupus or other things contribute to people who end up getting the skin injury. Having said that, there are still a lot of risks of radiation. And most of those risks, unfortunately, are to us as operators. So some things to think about. Only 1% of the primary beam actually makes it to the detector. That means 99% of it is getting scattered out into the room and to you and your medical student and your fellow in anesthesia. The head of the table actually receives the most radiation. 99% of the photons are absorbed or deflected, and the majority of it goes to your lower legs. So it comes out of the beam, it hits the table, it reflects down to your lower body, okay? The dose you get to your chest and your upper body is already attenuated through the patient, but still very significant. So just some numbers to keep in mind that I thought were kind of interesting. The US whole body limit for radiation workers is 5,000 millirems per year. 2,000 millirems per year for international whole body limit. So, and limit for the member of the public is only 100. So interventional healthcare workers have limits that are 20 to 50 times those of the general public. Some other important things to keep in mind is that interventional radiology physicians have about 3 millisieverts per year. That's like almost 3 times what a nuclear power plant worker gets. So we're definitely getting a lot of exposure. We have 6 times the risk of cataracts. Actually, on some retrospective reviews, 60% of interventionalists that were screened had cataracts or early onset of cataracts. And the average brain exposure, this is the scariest part, is 10 times greater than the whole body exposure limit. And there are a lot of incidental and scattered reports that left-sided brain tumors are higher in interventionalists because we're usually standing at the right femoral access position. So other occupational hazards of our job is wearing that lead. I know I have a lot of back problems from it. And so it creates other problems as well. A lot of people retire early for back pain and things of that nature. So we looked at, starting several years ago, who gets the highest dose and what are those cases that we need to look out for. So in this little diagram here in this paper, basically the A position gets twice as much as the B position. The good news for any medical students in the room is that the C position is almost 0 for any case because they're about 6 feet back. So if you can get about 6 feet back from the beam, the scatter's pretty low. Interesting for us, the D position at the left brachial axis position was almost twice as much as A. So that changed our practice. We stopped doing fenestrated endografts from the left arm axis, and we use right arm axis for a lot of our FEVARs, and published that we don't have a higher stroke rate in crossing the aortic arch with our catheters, and it does decrease the radiation we use. So looking at the case breakdown, FEVARs obviously were higher. The next case were like complex embolizations, and the table-mounted lead skirt was really effective at decreasing lower body dose. So we always need to make sure we're wearing that table-mounted lead skirt. Obviously, it doesn't decrease upper body dose because, again, your upper body is already coming through the patient to you, but still important. So something I'm going to be presenting, I think, at the SCVS coming up is just, it also depends on your level of training, right? So PGY6s for the same cases had a lot more radiation than PGY7s because they're running the machine. So all this basically tells you is you need early training in your residency or your fellowship so that you can limit dose as much as possible. FEVARs, when you break it down into, for people who don't know what FEVARs are, fenestrated endovascular grafts. So doing a complex thoracoabdominal aneurysm, which is wires, catheters, and stents, no open incision. As you can imagine, the more complex, the higher the dose. 4 vessels higher than 3, higher than 2. Custom-made devices are higher than off-the-shelf devices. So what is the good news in all this? The good news is in all of this is if you definitely apply some basic techniques, you can lower dose. So this was one of our first papers. I looked at all the radiation dose in all our cases 6 months before our medical physicist came to talk to us after we had a sentinel event, and then all the cases 6 months after. And just by applying some basic techniques, you can definitely protect yourself a little bit better. So we're going to run through just a few of those. So as I mentioned, DSA, digital acquisitions, when you stand on the pedal and everything goes white, it's like beep, beep, beep. That is significantly exponentially higher dose than just fluoro. So if you can ever just use fluoro looping, so if you're doing your access shot and you do it under fluoro and then you tell the x-ray tech to loop it, it'll keep running under fluoro. That saves a lot of dose over time. If you're just sure you're trying to get into a renal, you're in a renal, you need to make sure you're in the renal, do it under fluoro looping. So all those DSAs add up over time. Angio multiphase should be something your system is set on. Basically, it's reducing the frame rate in later stages. So when you're doing a critical limb ischemia and there's like literally no runoff and you're standing on the pedal, you hear the slow down because it's taking less frame rates on purpose to decrease your radiation exposure. So limiting magnification and using collimation is super important. So when you hit the mag button just one time on a flat panel screen, you increase your dose increases inverse proportion to half the field size. So mapping it up once doubles your dose. And so it's important to try to limit your mag. If you really have to get an image bigger, we've kind of found a solution for this. So on most systems, most flat panel systems, there's some ability, this is Philips, but Siemens has one as well. There's some availability to do like a digital mag. Basically make the picture bigger without increasing the resolution. Okay, so it doesn't increase your dose. So when we use this for our complex fenestrated grafts compared to the routine magnification, we are able to significantly drop off dose for patients and operators. So if you're not familiar with how to use dual fluoroscopy with live digital image zoom, call your Siemens rep, your Philips rep, your Zigo, whoever, and they'll help you do it because most people have a similar system. So just 2 sentences on your table position. This is important, especially on your testing, your V-side and your boards. It's important to keep the table as high as possible. And that system is just because there's a feedback loop. You want to keep the patient's skin above the reference air chroma point if possible, okay? Because radiation decreases is 1/r² from the source. And so the further you get the patient from the source, the further their skin dose is, the less skin dose. Now, the image receptor, though, needs also a feedback loop, needs to be as close to the x-ray tube as possible so it doesn't feed back and say, I'm far away, drive up the image, because all images are kept the same intensity at the image receptor. So that's why we say raise the table and lower the II. So just some other quick things. Try and keep the arms out of the beam. For FEVARs, actually, we started taping their arms up over their head for hours, actually, and they're okay. Because when their arms are done in a thick patient, it really increases your radiation. So if you can get the arms out of the beam, that's like a trick we've used as well. So some other little things that we've done at UT that have helped is usually there's a CT overlay for complex aortas, and you can map that to either a CT cone beam image that you do on table, or you can map it, we realize, to just 2 X-rays in a LAO and RAO. When you don't use the cone CT in the room, it decreases your patient dose by at least 20% per that case. So definitely try and do that if you can. Then not everybody has access to this, but we recently got the FORS technology. It's amazing. The FORS technology uses light energy. Okay, so we don't use fluoro at all. You put a catheter in and you set it up to your CT overlay and you're not even standing on the button and you see your wire and you can cannulate things based on your CT overlay. So we were able to do this type 3 thoraco with just IVUS and FORS cannulating all the vessels from upper extremity access. So it's one of those new technologies that's coming around, and so it's good to try and grab onto that if you're able to get access to it. So the other point, especially if you're going into a job, is to really look at what software is on your machines, okay? Because if you're in an old machine that's leaking radiation like crazy, you're doing yourself and your partners and your anesthesiologist and your OR team a disservice. So there's new software updates on almost every machine that has dose-saving software. So for instance, we studied this machine, this is Philips, and when it had some adaptive noise reduction algorithms, when we had that placed on the machine, that's all we did. We did some cases before and after, and we were able to show a 60% dose decline just from the software installation. It was expensive, but you have to go to your hospital or your chair and say, listen, this is a really serious problem and we need to do this. So Allura Clarity is the one for Philips. We also have Siemens on our Parkland system. So we got that upgrade. That one is called the Clear Imaging Pure platform. Same thing though, it decreased dose by at least 50% without changing anything else. So when you go into the community, when you get a job, make sure you're in a hybrid room that has the best software to protect yourself and your colleagues. Something that I'm talking about at VEIF tomorrow in New York is the EGNEST system. So this is a new company. I have no disclosures. I'm not involved, but we are buying it for our system upgrades that we're getting at UT. Basically, it's a shielding system above table, below table, and it has this really cool ceiling beam that's attached to the table that comes down and encompasses the patient like an egg. So all the fluoro is kept in that circle. And I'll show you some additional pictures, but it really is significantly decreasing everyone's dose. Works a lot better than the ceiling boom that never ever is positioned correctly and never comes in and always gets contaminated. And so, this was a multi-center study. This just wasn't some of my data. It was cases all across the country. And basically the EGNEST decreased dose at your thyroid and your waist and anesthesia kind of throughout. They're even suggesting that you won't need to wear lead anymore. I don't support that. I would still wear lead until I further study it. But it is a very interesting technology system. And all things considering, it's not that expensive compared to some of those other spacesuits and things that are out there, which I think you guys may even have one of. I was talking with Misty the other night. These are cheaper and they protect the whole team, right? The spacesuit thing only protects the primary interventionalist, but this protects the whole team in the room. So some good news in all of this is that you don't have to break your back with 0.5 millimeter lead. So we did study this. I think we presented this at SVS last year, is that the thinner lead, the lighter weight lead, is actually just as protective. And so I've gone to using the lighter weight lead, but there are a few caveats to that. So the lower leg wraps are super important if you're doing complex aortas, I think, because like I said, the majority of the dose to your entire body is your lower leg. So we've shown that those significantly decrease dose, and especially for the women interventionalists in the room, the leaded arm sleeve is crucial, okay? Because the majority of breast cancers, like I'm not a breast surgeon, so forgive me if I'm saying something since I'm talking to a Department of Surgery group, but is usually upper outer quadrant, at least years ago when I did general surgery. And so what we studied is that without the sleeve, your upper outer quadrant chest dose, even though you're wearing a sleeveless vest, is significantly high. And this is also in the orthopedic literature, that adding that arm sleeve, it's not very expensive, it just Velcros onto my lead, definitely protects that lateral chest wall dose. So I like to spend a few minutes to talk about what doesn't work for radiation. So this is kind of interesting, right? Because we all buy these. I mean, maybe not everybody buys your leaded surgical caps, but probably almost everybody in here who does radiation wears leaded eyewear. And we've done a lot of studies on this. So they don't work at all, actually. They're completely ineffective. And the reason is, this is my partner, Dr. Tim Ron, smiling because I'm taking his picture. If you think about it, the leaded eyewear is a lens that's lead. It can only attenuate 90-degree x-rays at your eye. You can see here, he's looking at the monitor. He's not looking down like this, okay? So the majority of x-rays to your eyes are from scatter radiation coming at oblique angles, not protected by the glasses or the hat. So the no-brainer hat doesn't work. Any leaded caps don't work. They're just hot, sweaty, expensive, and ineffective. And so we've studied this. So this was a paper we published a few years ago on the no-brainer hat. They probably weren't super happy with me, but they basically say that it attenuates 70% of the x-rays to your brain. Well, it does attenuate 70% of the x-rays to your outer skin dose on your temporal position. But we used an anthropomorphic head phantom and radiated nanochips in it, and basically showed that there was no attenuation, so zero protection or attenuation to your eye, your midbrain, your skull, or your upper brain. So it's totally fake news. Temporal dose is not brain dose. So you don't have to wear those anymore. We also studied multiple forms of eyewear that are on the market, leaded eyewear, even the leaded eyewear with side shields. And you can see here standard eyewear is all 3 or 4 different forms. What I did to modify it in this manuscript was I just took lead and taped it so I didn't get lead poisoning. I put like tape, like protected it. This is like, garage kind of science here, like without a grant. But we taped it all around my face, and then I did cases. And I studied the radiation before with it and without it. And then we also did an anthropomorphic head phantom. So when you protect the outer under surface and lateral face, you can decrease radiation to your left eye by about 62% in clinical practice. Whereas there's no dose reduction, so 100% dose with the blue, with the standard eyewear. So kind of interesting there. So we took that, and this was the phantom experiment. So in the phantom, you're actually able to put the nanochips in the left cornea position, the lens position, the temporal position, and all of those. So here you see the standard eyewear, which is just, leaded eyewear. The red was the leaded eyewear with the side shields, because years ago I bought that. I was like, I'm going to get the ones with the side shields to protect, which also was ineffective. And then the blue was just when I taped lead all around the glasses, and we saw a significant difference there. You see a higher significant difference in the phantom study because it's a static experiment, right? You're not, because in practice, you're turning your head, you're spinning, you're talking to anesthesia, blah, blah. So we got about a 60% decrease there, but with the phantom, you can get a really, really good decrease. So we took this a step further, and we designed actually a patented face shield that just slides onto your glasses. It can be any glasses, and that was the point of this manuscript here. It just bends over the bridge of your nose. It has an adhesive strip to stick to your mask. And basically what we found was you got an 83% reduction to 85% reduction, whether you wore it with leaded glasses or whether you wore it with just your prescription glasses or your splash guard glasses, your ones from Home Depot or whatever, because we're all supposed to, be wearing eye protection in the OR. So it significantly reduces your ipsilateral eye and your brain dose, actually. The good news is you don't have to wear it on the other side. We studied, because the majority of the radiation to your eye that's contralateral to the one closest to the beam is already attenuated through your facial bones and your brain, and so it's much lower. So you only have to protect your ipsilateral eye, and that, by way of deflection, protects the rest of your head and brain. And this is us in the clinical experiment. We found a 79 to 99% reduction with the face shield. And so something to keep in mind that's hopefully going to be coming commercialized soon. So just that alone can really save us, hopefully, this increased brain cancer risk that we're seeing in interventionalists. And I think that's all I have. Thank you. So I didn't realize I raced through that perhaps too quickly. But anyway, thank you. This is my family. I couldn't, do all this stuff without these wonderful boys in my life. So thank you so much. And I'd be happy to take any questions or answer anything. But such an honor to be here. And thank you so much to the family.
Well, first of all, thank you very much. And no one has ever gotten in trouble for having a lecture go short, so just remember that. The other thing I want to say is how incredibly timely this whole conversation is. And almost everybody in this room uses some kind of fluoroscopy, radiation in the operating room sometime, or they get called into a case where this is going on. And so I think having everybody have some awareness about this is really important. I also think it highlights how bad, for lack of a better adjective, the OSHA, if you will, the occupational safety things for surgeons is. If you think about what's happened with professional athletes and all of the stuff that's happening with head protection, et cetera, for baseball players and football players, and yet we do all of this stuff day after day with it's pretty impressive that the numbers are greater than nuclear power plant employees who probably have a lot of OSHA protections in place when they work in a nuclear power plant. So I think this is just the tip of the iceberg to an even bigger problem. So if you're looking for a broader career, you can take this lots of places. And thank you for doing this amazing work that seems so simple. I love your garage science. I think lots of things, happened that happen there that are really important. So I think this is great. Let's open the conversation to our folks in the room.
Hello, I'm Eric. I'm one of the new vascular interns. So I'm just getting started in the whole world of radiation, and I'll hopefully
Don't quit. It's okay. It's okay.
I'll soon be getting some lead, and I was wondering if you had studied like the different lead designs, like whether the 2-piece or the 1-piece, and like custom fitted is, better than.
Yes, no, that's a great question. I would definitely recommend the 2-piece. When you wear the 1-piece, every time you turn your back, you're getting a full dose of radiation to all of your organs because it doesn't cover the back. So I would never, and you think, oh, well, I'm facing this way, but that's not true. How many times do you turn to get the balloon or, turn to load the wire or whatnot? So I would say that the skirt and the other one, the apron are the best. Obviously, you need a thyroid shield. The other caveat point I'll make is if you are a pregnant trainee, you do not have to disclose to your team or your faculty. You can go to your radiation safety officer and they'll keep it confidential, and they'll give you a fetal monitor badge. It's an additional badge that you wear under your lead, and they monitor that monthly. Having said that, I had these 2 kids and they turned out okay. For now.
Before the advent of the fetal monitor.
But I did, honestly, with the oldest, I wore 3 skirts. So I was crazy about it. I was like, because I was doing all these high dose cases. And then the second one, I wore 2 skirts. I feel like if I had a third, I might have been skirtless. I don't know. Because my back was hurting so bad. But they all turned out okay. So you don't need 3 skirts.
Hi, Rachel Eckereb, Clinical 4 in General Surgery. Thank you for all the work that you're doing in this. My question is thinking from like a broader system standpoint. So we have all this data on what works, what doesn't work. I know that there are some great best practices guidelines out there because I know one of our chief residents in vascular surgery helped work on some of them. What are barriers to systems aside from the cost of some of these newer technologies? Aside from cost, what are barriers, do you think, for these practices being disseminated and taken up in a wider fashion? Is it just education, lack of knowledge? What do you think non-academic places need to do all this well, et cetera? Thank you.
That's a great question. I honestly, and I was speaking with the vascular surgery women, and again, may I compliment you and Misty for having a full division of women. I mean, this is probably the only division in the country that is all women vascular surgeons. So cheers to you guys.
Yeah, it's going to change in a couple of months, but that's okay.
But still,
we like to embrace diversity.
High proportion.
Exactly.
Yes. But I think the biggest hindrance,
searched high and low, but we found one.
I think the biggest hindrance is us. We're the biggest hindrance, and I do it all the time. The patient always comes first. That's been beaten into us since the day in and day out. So when it's my hand in the beam all the time, and I'm like, oh, I shouldn't have my hand in the beam, but like I have to hold pressure because now I have to pull the sheath back and deploy the iliac stent, and I don't want him to get a hematoma, and my hand's in the beam, or something's bleeding or rupturing, and you're just right in there, and you're not collimating, and you don't care, and you're magging up because you think you just ruptured a renal, and so the bottom line is we're a big hindrance. We always put the patient first, and we think, oh, it's no big deal, it's just one case, but one case is the next case is the next case, and it adds up, and then you have brain cancer. You know what I mean? Or you have breast cancer, which may have happened anyway, but who knows, right? So we as a group have to start protecting ourselves and saying, no, you know what? I know when I trained at Penn, we all stood here. We stood there right next to the DSA. I'm going to take 6 steps back now when I do the DSA, or I'm going to have my X-ray tech hit the DSA button from outside the room, and we all step back 6 months. You don't have to stand right there just because that's how I was trained at Penn. You know what I mean? So I think we have to take responsibility, and then we have to convince our hospitals to buy these things for us. And that's a big hindrance.
And that conversation's been going on here since I arrived.
Correct. So you mentioned stepping back. And so I wanted to get your take on, I think I'm the only one, and I'll still be okay with this. I use a power injector so that I can step away from the field and everything like that. Have you researched that? Does it help? Have you looked into those kind of things? And what is the data on using that versus using just hand injections from a manifold?
I think that's a great question, and that's a great life hack, right? I mean, truthfully, the reason why we don't do it is because everyone complains about, do I have to load the power injector today? I'm like, is it really that? So like we have hindrances on a lower level. The nurses often don't know how to hook it up, and then it gets contaminated. And I've got 6 cases, and I'm just trying to roll. And so again, we're the problem. I think that's a great idea. Load the power injector, step out of the room, and that definitely saves dose over time.
Thank you so much for being here and mentoring me. My question goes to the loop. I assume you're talking about the cine loop and
Yes.
how dramatically lower that is, and we really have to adopt that here. Do you think our vascular surgery in general doesn't do a good job of utilizing that and training that? Because I had never used it prior, but that could significantly decrease our dosage, or our technology is just getting better and we're getting new machines, so we don't think about it anymore. But I mean, it's not common practice to teach that we should be using that a lot more than we do.
100%. I think that's so true. And you train with me, and I don't even use it all the time. But when you have to have a tech, do you guys have a full-time tech in the room? They have to know how to set the monitor to turn it into a fluoro loop. So if you work well as a team and you can all go over, maybe it takes one day to go over all of these things with these people. Okay, show me how to do the electronic mag. Show me how to do all this. Work with your rep on the machine. You can learn a lot and maybe implement some best practices.
Abdul. Hi, Dr. Kirkwood. Thank you again. Abdul, Clinical 5, going into colorectal. Kind of a morbid question, but are there systems in place to capture those with disease progression or with cancers that are affected from like the radiation exposure, number one? Because the question I was thinking was, in order to have evidence to support, buying these machines, we have to demonstrate that protection does actually save these lives. So is there a system where we kind of keep track of people affected by this so we can show like lives saved and whatnot?
That's a great question as well. To my knowledge, no. And it's just anecdotal reports. I mean, that's the problem because, brain cancer is not all that prevalent, right? So just because there's reports that it's higher in an interventionalist population, that still might only be a handful of individuals across the country or in different regions. So there's no reporting mechanism. And I mean, for instance, we all talk about, there was a surgeon in, not in our practice, but in Dallas, a male who got breast cancer, who was always doing interventions. Well, but, maybe he could have just gotten male breast cancer anyway. So it's hard to pull that out, but we should actually, I agree with you, have a reporting system for when it happens, we flag it down, because that is the power behind it. Having said that, they do have a lot of policies in place for those nuclear power plant workers that we don't have. I mean, plus or minus, I mean, some people, like we're UT Southwestern, we have, 4 fluoro hybrid ORs, and in one of the neuro ones, I have a pregnant faculty that I had hired. She was our trainee, and she was pregnant. There was no lead skirt. I'm like, this is an OSHA standard. Like, how do we have? And so then I had to go through all this, and they're like, well, it's very expensive. It's like $3,000. And I'm like, how much is her life? You know what I mean? Like, buy the skirt. So, I mean, we have to get on the same plan with the MBAs who make the decisions.
Yeah, I think advocacy, there's so many points that you're raising here. And I do think figuring out how to do a long-term registry related something follow-up, we follow our patients. Yeah, I'm sure you could get lots of docs, and there's a lot of data on those little badges that you could try to correlate with individuals. I think that's a great plan.
Thank you very much. My name is Phil Chow. I'm one of the cardiac surgeons here. I applaud your work on advocacy for vascular surgery and radiation exposure and prevention and all that. Obviously, there are lots of other interventions out there. I work with cardiologists a lot. I mean, that's all intervention cardiologists, all they do, in the cath lab, doing this all day. Are there any collaboration out there between you or other vascular interventional group with cardiac intervention, like interdisciplinary collaboration on working on this to advocate?
And obviously our IR docs, a lot. I mean, there's a lot of people, and the days, general surgeons, pediatric surgeons. But I think you've highlighted too also high utilization groups.
Yes. So those groups actually use a lot more radiation than vascular surgeons. And we collaborate a bit at UT. Like we're going in with the cath lab to try and get the egg system in each hybrid room and in each cath lab. And there's some collaborations, like I've helped write some standards for different societies, and I'm usually on a panel with a cardiologist and interventional radiologist and all of that. But in terms of the meetings, I'm not sure they're focused on it as much as I think vascular surgery for some reason has been focused on it, because I was just at Viva, which is predominantly a interventional cardiology meeting, giving this same talk. And so I think you're exactly right. The power is in numbers, and there's not many vascular surgeons. I mean, Misty, 5,000 in the country or something, which is, pales in comparison to IR and interventional cardiology. And actually in this whole journey I've been on commercializing this patent that I have, the market is really them, cardiology, interventional radiology. And so I've been broaching into those markets and talking with those people to commercialize it. So you're right. We should all get out of our silos and work together on this, because that's power in numbers.
Absolutely.
Thank you for your talk. I was just curious, if you had enough money to pay for one additional accessory other than the thyroid and the two-piece lead, what would you advise residents or say somebody who's a government employee to get?
I would definitely get the sleeves.
Okay.
The sleeves, I think, are the biggest.
Female or not?
Yeah, female or not. I mean, okay. I would get the sleeves. The legs, I'll be honest, I don't wear the legs. I think you only need them for really high dose cases. But if you're going to be in there all day doing a really complex type 4 or something, the leg sleeves they're hot, but they're very effective.
Okay. Thank you.
Great question. Great answer. Thank you.
Thank you, Dr. Kirkwood, for your talk. You touched a little bit on pregnancy and protecting yourself when you're a pregnant trainee, but I wanted to ask you if you know of any literature about infertility rates among female interventionalists, and if there is any, because I think that's one of the barriers for women maybe applying into these fields, is a fear of that, and then also women in these fields and protecting themselves.
And it's probably not infertility as much as it is congenital anomalies in offspring.
Yes, no, that's a really great question. I don't know any specific literature on infertility, but I would say that there is a general, concern about that. I think, and I'm not OB-GYN, if there's any OB-GYNs in the room, please feel free to speak up. I have read some literature about how interventionalists have a higher rate of preeclampsia. Mm-hmm. I almost died actually twice with severe preeclampsia. I had HELP syndrome. So, but is that just because I'm a stressed out vascular surgeon? Maybe, so does it correlate more with being a stressed out interventionalist, or does it correlate more with radiation? I mean, it's hard to tell, but again, with more women going into vascular, and now there's a lot more women going into vascular, hopefully we'll be able to kind of parcel out what's going on. But as I showed that slide, I couldn't go into too much detail because I haven't presented it yet. But the trainee one, it's important. If you're a PGY1, it's really important to read about this stuff and do what you need to do, because hopefully if we catch women young enough, it might protect them against any infertility down the line if they get in on it right away.
Thank you.
Yeah. And again, I think the increased numbers that you've got in IR and cardiology might help ask this question. And those are fairly female-dominated fields. Mm-hmm. So I think this has been great. I'm sure. So first of all, I just did my recertification for my fluoroscopy license. I spent the whole plane trip doing all of my, and I wish I had read this first, because I would have gotten more of the questions right the first time around. So your timing, however, was great. And, I'm sure, again, this is my plug for, we all don't know what we don't know, and there's an opportunity to learn something with every new presentation, and having people like yourselves come visit with us. I suspect the family thinks, half of those words I didn't really know what they meant, but there's a message here that everyone can appreciate. So thank you again.